Alert Medic 1 respond.
3, 2, 1.
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
Hello and welcome to the Alert Medic 1 podcast. My name is Mustafa Siddiq.
And I'm Ken Sanner.
Today we're going to be doing something a little different. It's going to be more of an editorial conversation. We don't have any books and websites or anything in front of us. We kind of just wanted to talk about what we've been, talk further about what we've been discussing for the past couple of weeks regarding vital signs and diagnostics.
Yeah, just kind of an off the cuff, what's important, when is it important? Not really an addition in the vital signs series, but just a nice little wrap up to touch on some of the topics we've talked about.
Yeah, so I guess we should probably have a leading question. And Ken, my question for you is this. We talked about a bunch of different vital signs, diagnostics. If there was one you had to utilize, like say your ambulance was in some sort of disaster, I don't know, but you had to use one, what would you use?
If I only had one vital sign to go by to determine if my patient was sick or not sick, I would probably go by respiratory rate. I think that's what I would pick. Yeah, in the absence of all other clinical findings, that's probably the first thing I would assess.
Yeah, I think that's good because, I think we'd be looking at work and breathing anyway, but that's good. I would use capnography.
Capnography? Okay.
Yeah, and I guess I'm kind of cheating because capnography gives me the respiratory rate.
Right.
But I think capnography, and I didn't know this until I didn't know the scope of it. I understood what it meant, but I took it was like a 4-hour capnography course given by one of the people that make Untitled stuff. And the guy is like, I know you guys are using this to confirm your airways. Look at there's so much other stuff that you can use it for. And capnography can show you so many different things. Not only can it show you that respiratory rate, and it shows you, the exhalation pattern of CO2, and that's when we talk about like shark fitting and stuff like that. And I think every paramedic or, CRT or, an EMTI can rattle that off. But it's a marker of perfusion. When I think about Untitled, I think about cellular respiration. I think of it as a big circle where air comes in, it goes to the body for perfusion. And, cell respiration occurs, and then it comes back to the pulmonary circuit, and you breathe it out. If you have a lower number for your CO2, that means somewhere either your cardiac output's decreased or perfusion isn't going on. So that can give me a lot of really useful information. On the flip side of things, if I have a higher number, then I know that downstream the perfusion is still occurring, right? Like the cell respiration process is still occurring, but something is causing retention of that CO2.
And that retention, usually what we're talking about is a hypoventilation state, right? So hypoventilation and hypercapnia are completely and totally related and correlated.
Or like a pathological thing.
Or, could be,
bronchoconstriction or something like that.
COPD, asthma, stuff like that. But regardless of the cause, you're not getting that CO2 out. There's a problem there. Or you're producing too much.
So kind of like transitioning from a QA standpoint, what is one tool that, a diagnostic tool or vital sign that you feel isn't utilized enough?
Something that isn't utilized enough? I think respiratory rate is still up there, but to pick something different.
Not everyone has a respiratory rate of 20.
No, right? Isn't that shocking?
18,
yep.
Yeah.
But I think something else that is not utilized as much as it should be is temperature measurement.
Yeah. No, so I feel like people don't measure temperatures.
They don't,
and then
even on patients who really need it.
Or they don't understand that you don't necessarily have to have a fever to be septic.
Correct.
Right? And
yes.
I think sepsis is going to be something we're going to be talking about. I actually just had a conversation with a paramedic yesterday about how, we were just breaking down one of her rough calls that she had. And she said, well, the patient didn't have a fever, so she wasn't septic, but everything else pointed to a extended septic state, right, where the patient had been down for a while. Yeah, I think definitely temperature management. I think people don't put patients on monitors enough.
No, yeah, people definitely, in a previous episode, we talked about how syncope should always be an ALS call. And it's true, patients should be going on the monitor. One way I heard it that I really liked is if your patient had a complaint from the waist up to the neck and anything in between, that patient should have an EKG done. and maybe it doesn't have to be quite that extreme every time, but I think that's kind of a good guideline. If you've got a patient complaining of abdominal pain, you really don't know that that's not a cardiac issue. Now, in some cases, it may be kind of obvious. They might be febrile, they might have diarrhea, stuff like that. Probably not a cardiac thing, but if they just have some unexplained abdominal pain, that patient really needs to be on the monitor and have a 12 lead or 15 lead or 18 lead ECG done.
And the thing is, what's it hurting?
Right, nothing.
People, I think people get upset because they're like, oh, it's going to upgrade a BLS call to an ALS call. And that's a whole nother topic
right.
of burnout and stuff like that. But you got to, from a purely clinical standpoint, you got to do your job. Number two, people don't understand that you don't have to have a cardiac complaint to do an EKG.
Correct.
Right? And that was something earlier on that in my training, I had a paramedic tell me, well, they're not complaining of chest pain. I'm like, there's so many, and we discussed this in our EKG, there's so many other things you can pick up
right.
in an EKG.
Well, even if they're not having chest pain, it doesn't mean they're not having a cardiac event,
Especially in
right?
elderly females.
Yeah, absolutely.
God, yeah.
Diabetics, these at-risk populations, you could have somebody who is, just short of breath, a little dyspnea, a syncopal episode, arm pain, jaw pain, dizziness. That's a big one. If you have a 75-year-old who says they're dizzy, there's absolutely no excuse not to get an EKG. It's pretty clear cut. That's something that should be done.
Especially when you look into the physiology of cardiac output, right? So stroke volume times heart rate. If something messes that up, you're getting decreased blood flow to the brain, and you show syncope, or you show something that is causing a physiological response. How are you going to measure that, or what's one tool that you can use to see if there is a significant cardiac issue? Your EKG.
Yeah, absolutely. That can give you a pretty good insight as to what's going on, at least electrically with the heart. Doesn't, like we said, doesn't necessarily correlate to mechanical action, but it can.
And I think one of the tools that we want to develop, at Alert Medic 1 pretty early on is we want to develop a comprehensive EKG course, in close correlation with our medical directors and some other folks that we've been talking to, because I think it's a much needed resource. Right? I think we do a good job at the basics in paramedic school, but there's so much out there, right?
Oh, yeah, absolutely. There's just no limit to the amount of information that you can really learn about this topic. So I would kind of turn the question back around to you, Moose, in that what is probably the least interesting vital sign or diagnostic to you? What's the thing that you're probably going to get last?
What am I going to get last? Pulse ox.
Pulse ox? Okay.
Because their skin tells me a lot, I think.
Yeah.
Right? And that sounds terrible, right? I don't want people thinking that I don't put people on pulse ox, because I feel like at least one person is going to think that.
Right.
That's not the case. But in the grand scheme of things, we walk in, right? The patient is tachypnic, diaphoretic, so breathing fast, they're sweaty, and they look sick. I am not rushing to get a pulse ox on them. And people I'm a fan of room air sats before intervention, if you can do it, just because it shows you a trending of how sick they were to how sick they are after you get interventions. But what is the last thing I'm going to use? Probably pulse ox, because I can get a heart rate pretty quickly, right? Even if I don't get a full heart rate, I can see if they're tachypnic or bradycardic, right? Tachycardic or bradycardic. Blood pressure is pretty quick, and I would argue, especially in a patient who's sitting, you're not in a moving ambulance, pretty accurate, I would like to think. So that's heart rate, respiratory rate you can get, capnography you can get is very important. Temperature is pretty easy to get. EKG is pretty easy to get. We're going to talk about later about glucose. It's pretty easy to get. But and I guess pulse ox is easy to get too. But for what you're doing, for what you're getting, I'd probably do that last.
Okay.
What about you?
Yeah. So for me, probably the thing I'm least interested in, at least right away, is blood pressure, which isn't to say it's not important, because obviously it is. But I can walk in a room and know if you're perfusing or not. Yeah. It doesn't really matter to me for my initial management of you if your blood pressure is 90 or 190 systolic. My first question is, are you perfusing? If your blood pressure is real low, that's good to know, but I don't know. Again, I'm not saying that it's unimportant, because it's not, but I know without taking your blood pressure if you need immediate resuscitation or not.
So, and I think that the visual assessment of skin, right? So you're pale, patient who's diaphoretic and the mental, I feel like the truly
mental status is really key.
Yeah, exactly. Because what is dictating that mental status? One of the many things is blood pressure, right?
Yeah, cerebral perfusion.
And if you are not mentating, if you're showing the signs of a shocky state, then I'm assuming that your blood pressure is at least low,
right?
And it's not gonna. And I can agree with that too. It's not going to be one of the primary things I'm trying to get at.
But I am with you on the pulse ox thing, because even if you have, and we kind of went into this when we did the episode on pulse ox, but I have walked into a room, sat down and talked to a patient who appeared to be in no distress whatsoever, put the pulse ox on their finger, and it's 80%. Mm-hmm. And, with reason to believe that that was accurate. Vice versa, I've also walked into a room with somebody who's tripoding, one-word dyspnea, just looks terrible, put the pulse ox on, and they're satting at, 96%. It's just a number. It can help guide your assessment, but it is not the end-all, be-all of your patient assessment.
I think a good way to end this would be to just talk, and I think this is one of the big things that you definitely push when you're teaching. I try to push it as well, is the umbrella of the assessment, right?
Mm-hmm.
So you're not just using one tool, you're using a multifaceted, you're supposed to use quite a few different tools in your toolbox, and then your own clinical judgment, and your, not just the vital signs and diagnostics, but your own physical assessment, right?
Right. And one way I like to think about it is essentially like the tools are all findings in a court case, and you're the lawyer who's putting it all together and presenting the case and saying, okay, the totality of evidence, I really believe condition X is going on. Mm-hmm. And then you have to make that case to the hospital, to the receiving physician as well. But you can't make that case to them until you have an idea of what's going on with your patient.
Mm-hmm. Well, thank you very much for listening in, folks. Can you want to do your thing?
Absolutely. So thank you, everybody, for listening to the Alert Medic One podcast. Please remember to subscribe to our podcast, download if you so choose to do so, rate and review. That is so important. Leave us a rating, leave us a review. Find us online at Facebook, Alert Medic One. Leave us a comment. Let us know what you want to hear from us in the future. Check us out on Twitter at alert_medic1. Lastly, check out our website, alertmedic1.com. We're out there. We want to hear from you. We want to know what you want to hear about. Let us know what the burning issues are that are affecting you, and we'll do our best to address them.
Thank you very much for listening in, folks. Until next time.
You've been listening to the Alert Medic One podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.